I'd appreciate it. Oh, sorry. So my name is Mona Bormant, and I am representing the faith engagement team of Momentum Country and Global Leadership, and also Christian Connections for International Health. So I'm so glad you all are here. That's me on the screen. This is me in person. Just wanted to let you know who I am, and just we're so glad that you're here today. And I will be moderating today's session with 4 other amazing speakers. So you are very welcome, and we are glad you are here. Next slide, please. So why are we here? We believe that everyone has a basic human right to good mental, emotional, and physical health. So when we think of mental well-being, we believe it's needed for individuals, for families, and communities to thrive, yet mental health is often overlooked. And if you look specifically at adolescent girls and women, mental disorders are the most frequent complications during a very vulnerable time of pregnancy, childbirth, and postpartum. So that's what we call the perinatal period: pregnancy, childbirth, and postpartum. So you might hear that phrase also. And poor mental health during this time period, the perinatal period, has long-term implications on the health outcomes of adolescent girls and women, as well as intergenerational effects on children's health outcomes. So the statistic on the screen, I think, shows a lot of the importance of this, that nearly 1 in 5 women in low and middle income countries suffer from 1 or more common perinatal mental disorders, such as depression and anxiety. So it's not saying those are all or the only, but just examples. And we know that given the high prevalence of mental health conditions in this perinatal period, so in that pregnancy up to 2 years after birth, we believe that global attention to mental health is essential, and that communities must work together to provide hope and healing so we can all thrive. And a crucial part of communities are religious leaders, traditional and faith healers, pastors and imams, and other faith actors who are often some of the most respected voices who help shape community attitudes, beliefs, and behaviors. So that's why we really wanted to focus this toolkit and this webinar on why and how to engage faith actors as change agents for positive maternal mental health. So this toolkit that was created under Momentum Country and Global Leadership is designed to help equip diverse faith actors, so many different religions, many different communities. The context is super important in those communities and in those faith traditions. We want them to be equipped with information and tools to raise awareness, to talk about the myths and deconstruct those myths, and to address barriers that prevent positive maternal mental health. So we have 4 speakers today and 4 topics that we'll cover, and then we'll have Q&A. So if you have questions throughout the session, please put them in the chat box. But for now, I'm going to introduce the 4 topics and then our first speaker. For those of you who have joined, the QR code in the bottom right-hand corner is how you can access translation. And there's also a link in the chat box. So we hope that you're seeing that and that you're able to access translation. So our 4 topics today are: 1, to recognize mental health disorders and symptoms. The second topic is to know how to communicate to reduce stigma and misinformation on maternal mental health. The third topic is to discuss theological dimensions and different faith messages on maternal mental health. And our 4th topic is to understand how do we leverage social media messages on maternal mental health for faith communities, and how do we care for ourselves. So those are our 4 topics today. We're glad you're here. Once again, if you need translation, there's a QR code in the bottom right-hand corner. But it is my pleasure to introduce our first speaker, Millicent Muthoni. She is a clinical psychologist at AIC Kijabe Hospital in Kenya. Here in Kenya, I should say, I'm also in Kenya. So glad Millicent is here. She has her master's in clinical psychology and a higher diploma in psychiatry. And she has spent years really caring and serving for people who have mental health needs. So we are glad Millicent is here, and I will welcome her. Please turn on your camera, Millicent, and please join us to go through recognizing signs and symptoms of maternal mental health disorder. So over to Millicent.
Thank you so much, Mona, for the warm introduction, and I'm also excited to be part of this discussion. So as mentioned, I'll be discussing about recognizing signs and symptoms of maternal mental health disorders next. So as mentioned, before delivery and during the period end of delivery and postnatally, women will experience a lot of changes, both emotionally and as well physically. And a lot of times what we have discussed mostly is about baby blues. Those are the sad feelings, the emotional feelings that women experience immediately after delivery. But with science and with research, we now know that some of the conditions women experience cease from being baby blues to mental health disorders. And that's the reason why we're having this discussion, so that you as faith actors can help recognize the signs and symptoms of these maternal disorders and then provide the adequate support and referral system towards them getting treatment and also getting support from their healthcare providers. Next. So what are some of the contributors of maternal mental disorders? We can segregate them into two, biological factors and psychosocial factors. And one thing I want really to emphasize is a lot of times women, when they experience some of these challenges or some of these symptoms, they are seen to be as a result of their own fault or spiritual forces. And we want to demystify that and clarify and say that it could be as a result of these two main categories of factor, which interplay as well. So in terms of biological factor, genetic predisposition simply means that maybe there is family history of psychiatric illness. That is already a risk factor for one being more predisposed to getting a mental disorder. But that doesn't mean that everyone who has a family member with a mental disorder will get, but we know it is a contributing factor. Medical complication, if one is diagnosed with a medical condition during pregnancy or before even pregnancy, for example, maybe something like hypertension or diabetes, it could be a precursor for them getting really worried and anxious, so making it a contributor of some of these mental disorders. Lack of social support, we see this a lot, especially amongst pregnancy, amongst our teenagers, where there's lack of support. That also pushes them towards these conditions, relationship issues, unplanned pregnancy, and also history of abuse. So if a woman has been through abuse or is experiencing abuse, then they are also at a very high risk of these maternal mental health disorders. Next. So this is still a continuation of the same, some of the risk factors, and one that I really want to emphasize as well. So when a lady delivers and the child is probably admitted in the newborn unit, maybe it was a premature, it's very distressing. It's a very distressing period because there's a lot of anticipation on what is the outcome, what is going to happen about this child. When we have mothers as well who are diagnosed with HIV, that also puts them at a high risk as well. Some of the issues as well we encounter a lot is obstetric trauma, like child complications, disrespect, mistreatment, amongst others. Next. So I'll focus on the common maternal mental health conditions. There are many, but we want to focus on the most common because we know most common things occur more commonly. So we want you to be vigilant and aware about the first two. That's generalized anxiety disorder and also major depressive disorder. So the other one is postpartum psychosis. I will not dwell a lot on this because it's not as common, but we know it happens, and it's been one of the main contributors of mortalities amongst our mothers, both the mother and the baby, the postpartum psychosis. So going back to generalized anxiety, just as the term generalized anxiety, all of excessive worry, stress, and fear. So giving an example, maybe you'll find a lady really struggling and spending a lot of time worried about the wellness of the child, and will keep on checking on the baby, not even sleeping, keeping on checking to check whether the baby is okay or not. So meaning that they are preoccupied with worry. So there's also the feeling of being alone. Postnatally, a lot of people experience feeling alone because everyone tends to keep to some extent. They could also experience inability to prioritize tasks, and because of the worry and stress, that has an impact on the sleep pattern. So meaning that they will also experience difficulty in sleeping and also affecting the physical symptoms. So when a lady has 3 of these, right, for a duration of time that is probably also affecting their normal functioning, then we would label that as generalized anxiety disorder. Next. So the other condition is about the maternal depression. So we can either have prenatal depression, that's meaning during the before delivery, also the period of delivery, women can also experience the same, and postnatally. This is common, and some of the symptoms that the women will experience is feeling sad. Yes, we talked about the baby blues, but I want to really emphasize that not every feeling sad is baby blues. Feeling sad, most of the time you'll find that they will have lack of interest, like they will neglect some of the duties, like even getting out of bed. You will also find that they will have attachment challenges with their newborn. So they will feel irritated and annoyed by the child. They will also have challenges in breastfeeding. They lack that motivation. They will have feelings of guilt. Some of the mothers that I have seen will even have doubts about being good mothers. And at times it gets to the point of self-harm and even death by suicide or little one, the baby. Next. There's also lack of energy, and you will find either a mother eating too much or eating too little, meaning that the appetite is affected, challenges in sleeping, trouble remembering things, and also irritability. And one of the other things that I can emphasize, when you are faced by maybe a couple who are having argument, because this is something that also causes constraint in a marriage, when you find a couple coming to you and seeking help because maybe they have constrained relationship, it was important for you to evaluate, could the lady be ailing from major depressive disorder? So when there are 5 of these, then we would say that that's MDD, major depressive disorder. Next. So in terms of outcome of common maternal health disorders, so one of the things you will find that if our lady is depressed, it's unlikely that she will attend antenatal clinics, meaning if she doesn't attend antenatal clinic, the baby outcomes are going to be not the best. So inadequate nutrition, you will also find that they will probably be at risk of complications as well. These are the same things that we really want to also mention about preterm and low birth weight have also been attributed to some of the maternal mental health disorders. There's also lack of ability to attend postnatal care. And if a lady is not attending postnatal care, of course, she will not also have her child immunized. So meaning that the child is going to be affected. And then we've talked about self-harm. The other bit that happens for the baby is because of the poor attachment, the child will not exclusively breastfeed. If the child doesn't exclusively breastfeed, we expect that they will have stunting. They will also be underweight. There will be poor attachment, and this might even progress beyond the period of postnatally, even as the child grows. And also there will be also likelihood of the child getting multiple illnesses, experiencing childhood illnesses. Thank you. I want to take it back to Mona. Thank you.
Thank you so much, Millicent. I know that was a very quick overview of some mental health disorders and symptoms. There's much more information in the toolkit, and a lot of what you can be what Millicent spoke about can be found in table 1 and table 2 and some other areas in the toolkit. So we do hope you look at that, and we included the toolkit link in the chat box, but thank you, Millicent. We'd like to move to the second topic of today, which will be covered by Anne O'Tween from Bishop Stewart University in Uganda. She's the Dean of the Faculty of Nursing and Health Sciences, and she has a master's degree in counseling psychology, but she's currently also doing a PhD research fellowship in psychology at Makerere University in Uganda. So we welcome Anne. She will be talking specifically about religious specific teachings, and a lot of what she will be covering is also found in Annex 3, 4, and 5 in the toolkit that has much more depth than what she'll be able to cover today. So Anne, over to you and to our next topic. So thank you. And once again, in the bottom right-hand corner, if you need to access translation, there's a QR code that you can scan. So welcome, Anne, over to you.
Thank you, Mona. Thank you for the opportunity to share about the role of faith in caring for people with maternal mental health. Next slide. So we recognize that maternal mental health is very common. It's very common in low and middle income countries, although so we want to appreciate that even in our respective areas we are coming from, we see a lot of mothers and young girls going through maternal mental health issues. And in this particular topic, we are looking at the role of faith leaders. And one, we know that health leaders have been instrumental as part of the treatment team for maternal mental health, especially depression and anxiety in our religious settings. And as Mona had already indicated, most of the faith leaders have been very key in providing help to women and girls suffering from maternal mental health. Secondly, we also recognize that often girls and women, when they get maternal health challenges, the first place they run to is to their religious coping methods. And some of these, we find that they find strength in prayer, they find healing, and they also take time to cry to God for help. And often it has helped support them get out of the depression and anxiety that they experience. And thirdly, we also want to recognize that in day-to-day activities, we find faith leaders very instrumental in supporting women and girls who are going through mental health illnesses. And they visit them, they pray with them, and in the unfortunate circumstances, in case people die, you find that the faith leaders are the first people who go to visit homes to provide comfort. So we really recognize and appreciate that faith has a role to play in the treatment of perinatal mental health. Next slide. We have three main common themes that run across the Christian, Muslim, Hindu, and Buddha, and many other faiths. One, we find that these faiths, they emphasize support for mental health and well-being. So you find that when they are engaging their faithfulness, if they are faithfuls, they are always speaking support, they are speaking well-being. And secondly, we recognize that theologically, mental health disorders are neither punishment from God nor caused by sin or wrongdoing or karma. So as faith leaders, we need to let our congregation know that mental health disorders are not a punishment from God. And thirdly, faith actors are very critical in offering compassion and support for those who are suffering from mental health in our communities. Next slide. Yeah, in this presentation, we want to show that mental health is not new. When we go to the holy books for Christians, for Muslims, for Buddhists and Hindus, we find that some of the patriarchs of faith, some of the faith leaders, they struggled with mental health issues. We have an example of Jesus Christ when he felt overwhelmed to the point of death and cried to the Father. We also see Joseph when he lost his sight Jacob when he lost his sight because of grief of his son Joseph. And we also see from the Bhagwan where it is also saying that mental health is a state of the mind which really affects our faith, especially when it comes to a relationship with God. So we cannot shy away as faith leaders that mental health does not occur to the general population. Next. Next, please. Yeah, however, the good news is that our holy books still carry messages of hope, which as faith leaders we can share with our faithfuls, which as faith leaders we can pass on to the women and girls who are suffering. For instance, we read from Psalm 34 that when the righteous cry out, the Lord hears them. Also in the Quran, you know, it is stated that it is only God who can be the healer, who touches where no man can touch, and the Bhagavad Gita. So we are being encouraged that as faith leaders, we shouldn't shy away from sharing our faith, from helping people to reconnect with God when they are going through mental health challenges. Next. Yeah, and these are some of the activities that faith leaders can do with people who are suffering. One, you can pray with them, encourage them to read religious texts, encourage them to seek forgiveness and also give forgiveness, and also encourage them to participate in community so that they feel they are serving God, encourage them to seek counsel, and also care about their physical health. And in case things are not right, that these people could be referred for medical care. Next. Next, please. Yeah, so in this slide, we encourage faith leaders to design messages in their respective congregations, which can encourage the congregations to care about the girls and women who are suffering from mental health. This can be, as Mona said, the details can be obtained from the annexes 3, 4, and 5 so that when we go back into our congregations, we can design these faith messages, and then we encourage or sensitize our communities to care for the needs of women and girls who are suffering from maternal mental health, so that they can be restored back to the will of God, where in Him we have fullness of health. And the next slide also shows the brief summarized template where these messages can be used. Yes, so we can use these templates to write the supportive messages, and also we can share these messages through social media platforms, radio, television, and our congregations. I thank you. Thank you so much for listening to me as you develop faith messages to reach our women. Thank you.
Thank you so much, Anne. It was a pleasure to hear from you, and once again, just a glimpse of what different religions might say about this topic. So I put the link to the toolkit in the chat box. Here's my printed copy. I don't know if you all can see, but if you look in just an example, Annex 4, for example, has Muslim-specific teachings that's 2 pages long. So what we put in this presentation is just a very short picture of what is actually in the toolkit. So we hope that you refer to the toolkit, that it be a good reference for you moving forward. So thank you, Anne, for sharing about different messages and encouraging people to think about what kind of messages can be used specifically when talking to people of faith or to faith leaders. So thank you. I'd love to move on to our third topic, which will be presented by Clayne. But before I do that, if you have any questions for Millicent or Anne so far, please put them in the chat box, and please tell us who your question is for. So that will be really helpful, so we can direct the question to the correct person. But just wanted to remind you all about that. So our next speaker is Clayne Nyiramahoro. She is Rwandan and works for SIL International as a trauma healing master facilitator and coordinator. She's led trauma healing workshops all over Africa. She's published a book, and she believes God uses our brokenness to encourage others in the kingdom, to give hope to the hopeless. So we are glad that Clayne is here, and she will be sharing on our third topic, which is how do we communicate to reduce stigma and misinformation on this topic specifically. So Clayne, I will turn it over to you, and I'll just remind people again, if you need translation, please access the QR code at the bottom right-hand corner. So over to Clayne. Thank you.
Thank you, Mona, for inviting me, and I'm happy to be part of this conversation. And I'm going to be talking about how do we communicate to reduce stigma and misinformation. Worldwide, it has been found that women and girls who experience mental health, they also face stigma from families, stigma from communities, and a stigma sometimes from their religious communities as well. And the people who are supposed to provide support, sometimes you find that they are the ones to actually perpetuate the stigma. Next slide, please. And when we talk about mental health, we need to acknowledge and recognize that the mental health presents itself on a continuum, away from the healthy part of the continuum to the far left of the continuum, where the person is really ill. And when we are healthy, we are functioning properly, we are able to take care of the things that matters, we are able to sleep well. But when something interferes with our normal ways of doing things, we find ourselves reacting, and more so for women who have either experienced experiencing this mental health due to pregnancy or after they have given birth, they start being irritated and reacting. Sometimes you find yourself procrastinating and you do not sleep well, the level of energy is low. And at this point, if somebody receives proper help and support, they can come back to the healthy status. But if not, we actually find that women can be injured or ill at the stage where they really need professional care because they cannot control their emotions, they cannot control the anxiety, they get panic attack. And sometimes to the extreme, you can find that some women will even have some suicidal thoughts. So it's very important that this professional care is provided, but also without ignoring the social support and the self-care also that individuals need to provide for themselves. Next slide, please. And there are steps for faith actors to address stigma, because one of the ways that we can address stigma is to adjust our thinking, because in our thinking, sometimes we have wrong attitudes towards people experiencing mental health, or we are very judgmental. Sometimes when women are struggling, rather than getting support, they're actually judged based on how they look, how they behave, and that can only make their situation worse. And we need to be able to openly talk about mental health. It's not a taboo to talk about it. And as somebody who is suffering, it's not their fault. So as we talk about it in a healthy manner, it also contributes to help the person suffering to recover. And as we talk about it, we also need to choose our words and questions very carefully, because if we are not, then we can also fall into the trap of judging the person. And rather than encouraging, we actually push them further into the pit. And we need to be compassionate. We need to show respect, respecting the dignity of the person suffering. The fact that someone is sick, it doesn't make them necessarily being the wrong people, or it's not their fault. We need to be able to respect them as a normal human being. And foster belonging is very important, providing community where people feel they are not rejected, they are not discriminated against. That helps in their recovery process. And also not forgetting building bridges, being bridges to the people suffering to access treatment, to access resources in the communities, the resources that will help them feel well and feel better. And we need to be role model. If we are asking people to do self-care, we need also to show the example that we are able to take care of ourselves, and also being vulnerable. If most of us mothers who have gone through this, we can be vulnerable by sharing our experiences to younger mothers, and also letting them know that whatever they are going through is normal, but they need to be helped. Next slide, please. And this is a pathway for mental health communication. And the best way to engage the people who are suffering is by asking them questions. Usually when you ask a question, it's almost giving the person permission to be able to express what they feel. And as they express themselves, we also need to be able to have the right attitude, to provide the right knowledge that they need, that they need to take care of themselves, the right information on mental health, or even providing some other resources that may be helpful for them to take care of themselves. And as we do that, we also need to encourage them, engage them in dialogue, give them permission to ask us questions, or also us helping them to see how do they understand the information that we are giving them, and how do they intend to use it to improve their situation. Next slide, please. And as we talk about mental health, We know also there are several myths surrounding this condition. And these are some of the myths. Some people think that mental health conditions are rare, struggle or suffer from mental health. Or some people think that mental health are permanent. No, research again shows that 80% of people who suffer from mental health, if they receive the right support, they can get well, they can get better. Or thinking that it's impossible to prevent a maternal health, maternal mental disorder. Again, this is a myth. It's not possible. We have seen, and the information content in this toolkit show that it's actually possible to recover and to prevent it. A mental health condition is a sign of weakness or lack of faith. This is another myth. No, it's not. In fact, if we acknowledge that we are suffering from a mental health disorder, this is a strength. It shows that we are strong enough, we are willing to be vulnerable and seek help. Next slide, please. And also people may think that only professionals can help the person with the mental health condition. Again, this is a myth. In fact, it has been shown that mental health professionals, they do their part, but there is a big part that need to be played by the community, by the family. Social support together with professional support will provide the necessary help that people struggling with mental health need to recover and to be well again. Thank you, and I pass the, I give you back the stage, Mona. Thank you so much. I think my time is over.
Yeah, thank you so much, Clayne. I really appreciate it. I think it's sad how many myths there are and misconceptions on this topic. And I appreciate that there's been a mention of the importance of, yes, in health facilities where people are going for treatment, there needs to be discussion, but also the importance of talking about this among our friends and our communities to just try to really reduce the myths and replace myths with good, correct information. So I really appreciate you sharing, Clayne. I just want to remind everyone that please do put any questions you have in the chat box. And if you have a question, if it's directed towards a specific speaker, please let us know. Otherwise, we'll just ask the question generally. But really do appreciate you engaging with us so we can have a robust discussion after our last speaker. So our next speaker is Erin Hiffer. I hope I said that right. She's a senior technical expert in global maternal and child health, and she was our lead author on this toolkit. So very grateful Erin could be here. We've worked closely with her on a variety of topics, and she will be sharing about how do we leverage social media messaging on this topic, but also how do we promote good maternal mental health and our own self-care. So Erin, welcome, and over to you. Thank you.
Great, thank you. So the toolkit really does include a lot of very helpful information that has been pre-written so that faith actors can leverage social media. We know that social media is used all over the world, even in areas where technology adoption is somewhat lower. It's quite pervasive and it can be quite a powerful tool. Next slide. So radio and other social media platforms, whether that be Twitter X, Facebook, Instagram, or other local platforms, even WhatsApp messaging, can be used by faith actors where they can use their influential position, their respected role in their faith community to encourage open dialogue about mental health and make this not have the stigma as we were just talking about. Social media is really powerful to influence social norms because you're reaching a large number of people with repeated messages. And when people see things over and over again, they come to learn and assume that other people are also embracing this topic and that the social norm is shifting in this direction. It can be also very helpful to dismantle stigma and make women themselves who may be struggling with their mental health feel more comfortable to talk about it, and for us as a wider community to support those women. Often by repeating key messages regularly across different social media platforms, faith actors can reach quite a large audience, much more broad of an audience than they would otherwise have if they were just meeting people face to face. And as I said, it can really normalize a topic like mental health, which can be a little sensitive of a topic to talk about face to face. Using technology and social media can put a comfort level between an audience like faith actors and someone who's wrestling with the stigma and perhaps sensitive nature of talking about mental health. Next, please. Personal testimonies from faith actors are especially powerful as a way to promote acceptance. If you see that your respected faith actor is talking about their own self-care, is talking about someone they know who's struggling with mental health, or maybe is willing to share different mental health challenges they've had and how they've turned to their religious scripture or mental health services to overcome that, can be really powerful for people. We saw the example of personal testimonies in the COVID pandemic, where really respected leaders were showing that they were getting vaccinated. And that helped reduce a lot of fear and stigma for a lot of their faith communities, seeing someone respected be willing to talk about a hard issue. And these can be told over social media as small quotes or vignettes, or little videos even, of just really speaking from a personal experience that a faith actor may have. And there's some examples of those given in the toolkit. Next slide. Faith actors can also show support of broader global mental health awareness initiatives by reposting content that's already out there by respected sources. There's a list of trusted websites in the toolkit, such as this one that is World Maternal Mental Health Day. Reposting that can show that the faith community is supporting these initiatives as well, and that together the faith community can support and encourage people to seek out mental health services and really love those people who are struggling with a mental health disorder. Next, please. One of the values of the toolkit is that we have several sections that already have pre-written, short, succinct messages like those that are shown here that can truly be copy and pasted into social media or adapted, if desired, into the local context. We tried really hard to make them specific to different religious contexts, but very easy to understand and short and easy to rewrite and hear across different social media platforms. There also is guidance in the toolkit of how many characters you're allowed to use in the different platforms and how you can adjust the messages accordingly. But one of the important things we know and we've learned about the power of social media is that repeating these short, succinct messages several times so that people see them here, they see them there, they hear them over time, is really how social norms will shift. Next, please. As I mentioned, the toolkit also does include specific religious text from Christian, Muslim, and Hindu scriptures or sacred writings that really reinforce the support of loving others through supporting their mental health. We consulted different faith leaders from each of those faith traditions to make sure that we were pulling the correct text that can show that across these religious traditions and others that are not listed there, there really is a collective support for promoting mental well-being, and that someone who has a mental health condition or is suffering from poor mental health needs our support. And so take a look at these annexes in the toolkit for the specific references. As Mona mentioned, a couple pages worth of text that can really reinforce some of the messages and show that not only is this something that the global audience is believing in, but that our religious background and faith also supports this. Next, please. There's also a section on just how the faith actor community can support self-care overall. So almost a preventive approach to mental health before someone slides into a poor mental health. How can we promote good self-care? Next slide, please. We know that particularly women often carry very heavy burdens across all cultures and across all geographic areas. And some of the cultural traditions, especially during pregnancy and the postpartum period, may not be helpful and may add burden to a woman's mental state and contribute to a poor physical or mental well-being for the mother. And so faith actors can step up and say that we want to acknowledge the hard time that is the period of pregnancy and postpartum, and that women need our support. And we can stand and encourage them to take care of themselves. We can take some of the burdens off of them to really allow them to not be overtaxed and overburdened. Next slide, please. These are examples of self-care practices that are listed in the toolkit. How do you encourage your community to help the women that are their mothers, their sisters, their daughters, that how can they take good care of themselves so that they have good mental well-being? There's a list of practices related to healthy eating and sleep, making sure that the woman is able to have time to relax and time to rest appropriately, and to have the social support that she needs and not feel isolated during this time of pregnancy and postpartum, which can be so taxing. Next slide, please. Faith actors can also lead by example and make sure that even through social media, as we were talking about, or through other platforms in which they engage with their community, they're talking about how are we caring for ourselves as a positive role model and example, and encouraging women to take care of themselves and offer to share some of their burdens and household responsibilities so that they can tend to their physical and mental needs, for example. I hope that you will enjoy all digging through. I know this was a very fast overview of the different resources, particularly that are provided in some of the tables and the annexes in the toolkit. But there's a lot of meat there, and we're excited that you are all here. Happy to have any questions.
Thank you so much, Erin. I appreciate you and all the other speakers and everything that you've covered today. We have a few questions in the chat box, but encourage others to write more questions. And before we do that, I just really want to say thank you to Momentum Country and Global Leadership and USAID for their support of this project. And I also want to thank everyone that we had multiple consultations when we were developing this toolkit, and names are listed in the toolkit, for which we're very grateful for the time and effort and feedback we received from everyone. So just really want to say thank you. There's a QR code here that you can scan to get the toolkit. We'll also put the link in the chat box and in the follow-up email. I would really love to ask you all or encourage you to make a social media post about today's webinar, what you learned about the toolkit, and to share it with others. You can tag Momentum and all of our speakers and our partners. But we can close the PowerPoint and we can move to Q&A. And so we'll ask all the speakers to turn their videos on, and we'll start with some of the questions. But let me pull up my question document to make sure I'm asking the right ones. We have some really robust questions so far, which are multi-part questions. So our first question is from Josephine from Healy International in Sierra Leone. She has a multi-part question. So she asked, how are faith leaders guided to better understand mental health as a disease that often requires medical treatment by a healthcare professional? And then how is that faith leader also a supportive presence? So they can walk alongside, but then they refer. And is that difficult if they're not trained mental health professionals? And how do we promote the integration of faith as a supportive complement to medical treatment, ensuring that they both work closely together? So I'm just gonna pick on people because she didn't direct this question to anyone. So I'm gonna pick on two of you, right? So I'll pick on Millicent and Anne. So does either one of you want to address the first question?
Sure.
I did send my comment in the chat. Maybe Millicent can go ahead and provide her own answer.
Sure, thank you for the question. And it's a really good question. One of the things that we can work towards is working alongside with mental health practitioners. And the reason why I'm saying this is because there are certain mental health conditions that we require more than even talk therapy. They'll probably require even medication. So it would be nice for faith actors to reach out and to work very closely. I'm sure in the recent times we've seen like the health docket getting into church, and we have within the church we have health ministries. So those are some of the things that can be discussed during those discussions on how best can you support client, and how are you able to identify. Also, the reason why we are doing this sensitization is to also prompt and help you think through some of the common conditions. So if you go to the toolkit, it's more elaborate, very elaborate on some of the key conditions. So you can go through it and identify some of the symptoms, so that when you have someone coming to you and reaching out, you're able to see, maybe I could be dealing with not just a social issue, not just something else, and probably this person requires help from a professional. Yeah, thank you.
Thank you, Millicent and Anne. So I picked on the two of you to start with, but Clayton or Aaron, do you have anything to add to this question?
You spoke beautifully to it, Millicent, and I hope that you're encouraged by the toolkit, because this is specifically addressed. I really appreciate your question. I think it's very important. It didn't get covered in our presentation here, but we did try very hard to use careful language in the toolkit to show where the role of a faith leader ends. And it needs to be the support that then refers and passes off to someone who has training in mental health service delivery. We know that in a lot of contexts, there are very few trained mental health service providers. And so that can be a challenge, but knowing that a lot of true mental health conditions need a professional to be able to walk through them. They can still be supportive. The toolkit talks about walking with them to appointments or checking in on them as they're receiving treatment, but knowing that the role of a faith actor is not to heal the person, but to really walk alongside them.
Thank you, Aaron. Clayton, anything to add?
No, I think they have said it well. I would just add and encourage anyone who is a faith actor to not to pretend that we know everything, but to actually get to understand the people in our congregation and the people in our community, and get the awareness that mental health is real. And when we do not know what to do, it's okay to acknowledge it and seek help from those who know what they can do with it. It's not a sin to have mental health. It's a sickness like any other. And sometimes praying alone will not help, but connecting with the right resources is also helpful. And also not to discriminate against those who are suffering from mental health, but creating as a community, a safe community where they can come and seek help. That's what I can add.
Thank you all. So I'm going to skip around. We have two questions related to men. So I'm gonna move to that question. So Martin from Moffat Bible College in Kenya, and then Sahil, where are you from? I'm looking it up, sorry, from Zimbabwe, have both asked about the role of men in relation to maternal health versus mental health. And Martin specifically asked, there are many faith leaders who are men. is there some available body of work or information that can refer them to on how to engage with men specifically, or young fathers on how to support mothers? So I'm not sure if any of the speakers have any information off the top of their head, or if we can refer them to something later, but I just wanted to ask. Any thoughts about men, mental health versus maternal mental health, or any resources you know of how to engage with men? So would anyone like to start? I picked on people the first time. I'm trying to be nice now.
I can just mention that the toolkit doesn't have a lot specifically to address the mental health of men themselves, but it does touch on specifically the role of how men and whether fathers, brothers can support women. I think that's a really good point. Some of those short, succinct messages I mentioned that are pre-written say things such as, men, let's support the women in our community by, in XYZ. So there's a little bit of language there. I think that's a broader topic that is a bit beyond the scope of this toolkit, but super important. And there are different groups that have created mental health models or tools specifically for men. And if I can snag them quickly, I'll put them in the chat box.
Okay, maybe I can thank you. Thank you, Martin, for the great question about men. One of the things maybe I can mention is, as faith actors, we can also encourage our men to get involved in the antenatal and postnatal care, because sometimes what women might report, not that they are lying, but sometimes I may not fully understand what is happening to me in terms of my mood and changes. So one of the things I would encourage, even when you're talking to your congregation, is encourage men to take up the role of getting more involved in the prenatal, antenatal, and postnatal care, so that even the issues that arise, they are handled on time. Thank you.
I would also wish to say that the message about perinatal mental health is not for women. It is actually for all of us. And we are, from what I discussed, especially the template, we are actually encouraging men in their men groups to design messages that address women mental health. So this discussion actually, it is all embracing, and we pray that men should not feel it is only for women. It is for all of us, because the women and the girls that are suffering, they are our mothers, they are our sisters, they are our wives. So it is high time we all come on board and then embrace this campaign about perinatal mental health. Thank you.
Thank you. Any other comments about male involvement? Maybe this is not appropriate, but I will say a girl or a woman doesn't get pregnant alone. And so I always feel like there should be men involved when it comes to caring for a mom at all stages, not just because of mental health, but physical health, economic stability, all the different factors that were discussed today. So I appreciate the question. I'm going to move to the next question. There were two related questions, maybe kind of. There was a question from Ebenet from Ethiopia about, has anyone considered the role of African traditional religions related to maternal mental health? Ebenet, it's a good question. I would be curious if you've had any experience in Ethiopia, which I know is a very Orthodox country, in terms of African traditional religious leaders. I think there are concerns about traditional healing methods and what type of information we're getting. But I think we focused on Christian, Islam, and Hindu religions. But I think that most of what is in the toolkit that is applicable to faith is also applicable to working with someone from an Africa traditional religion. That's just my quick response, but does anyone else have experience with African traditional religions on this topic or other topics. Anything they'd like to share? Thanks.
My comment is not probably how Africa traditional regions help deal with mental health, but maybe some of the cultural practices that actually make mental health worse. Sometimes when a kid is born and they don't think, some community think that if, for example, if we have some abnormality, some disabilities, some communities we think this is a curse, and some communities will either shun the mother and the child, or even in some extreme cases the children will be killed. And I think that would make you sure about some practices in African traditional region that are helpful. Maybe someone who knows can help us, but I know some practices that are actually make the mental health worse rather than helping.
Thank you, Clayne. And thank you. There's a lot of comments in the chat box, and I appreciate someone who said men are not spared from mental health problems, which is true. And we don't want it to seem that way. It's just our focus today is on maternal mental health. So thank you for that comment. I just want to go to another question. Sorry. So someone asked about online courses on mental health accessible to religious leaders. That's a really good question. I don't know of any specific online course that is for religious leaders on mental health, on maternal mental health. I could be wrong, but I don't know of any. I think there are probably online courses about mental health. I don't know if those mental health courses are specifically geared towards religious leaders. We'd love to work with a Bible college or a seminary or a madrasa or anyone that would be wanting to develop something like that. I think that's a really interesting idea. And Hamid, I think a very good question. Sorry, I don't have a more clear answer, but does anyone else know of anything? No? Okay. Another question from, oh, sorry, Anne.
And not really, except if someone maybe took a class or on counseling and then would engage in this or clinical psychology. However, we encourage faith training schools. We really encourage faith training schools to pick on this toolkit and integrate it when they are preparing the faith leaders, so that by the time they leave college, or even in the day-to-day seminars, sensitization can keep going on, so that we close the gap between spiritual. I think someone asked about the difference between mental health and spiritual well-being. So we cannot separate spiritual well-being from mental health, but the approach to science and the theology will be the one that will make a difference in approach to perinatal mental health. Thank you.
Thanks, Anne. I'm gonna move to another question. I don't know that we're gonna be able to get to all of them, but I'm trying to get to as many as possible. Dr. Andres from Mexico has asked, how do we promote an awareness that mental health and spiritual health are not synonymous? So Anne just touched on this, but does anyone have any other experiences or suggestions for how to address this difference in your experiences?
I can try. I think that going back to actually the earlier question about distinguishing mental health as something that is a medical condition, and that, yes, so that is distinct from your spiritual well-being. And I think that that can also reduce some of the stigma that sometimes is given to people suffering from mental health disorders, where there is blame or shame in that mental health disorder, that it is separate and distinct and is something that that person doesn't want or didn't cause as well.
Thank you. Maybe the other comment I could also add into what she's talked about is what we know in terms of outcomes when we have incorporation of the spiritual bit in the treatment, then there are better outcomes virtually. However, in practice, what you will find that initially when you have patients or people who are ailing from mental health conditions, they might feel very distant with God, and they will not even want to hear anything to do with God because probably they feel like He has abandoned them. But if you're working, and that's the reason why I was saying work closely with professionals, because it gets to a time when the client or this person is able to recognize that it is not the fault of God. And by that period of time, then they feel like they are getting closer in terms of spiritual, and that's the right time now to refer them back to the spiritual person to support the spiritual welfare. So I would really encourage that as professionals in terms of mental health, work with us very closely, because we all have a role, and the minute we work together, we're going to have excellent outcomes. Thank you.
Thank you, Millicent. Thank you, Erin. I'm going to move on to our next question. So Felix from Zambia has asked, what's your take on building this topic of maternal mental health into premarital counseling, so couples are also aware and have a chance for in-depth discussions as they enter marriage? Any thoughts? Everyone says yes. Everyone's nodding their head. So Felix, I think people think it's a good idea.
Sure.
So, okay, thanks. Perira, I'm not sure if I'm pronouncing that correctly, sorry, from Malawi, has asked, are there some beliefs that a real child is a boy or a girl and how that affects women? I think what this person might be saying is that in many contexts, people want to have a certain gender of a child. And so the pressure of that may affect a woman's mental health if she has a boy or a girl, and if that culture or that context wants her to have a certain gender. So not sure if anyone's ever dealt with that and how that's affected women in the work that you've done.
We see that a lot. Yeah, cultures and the certain beliefs actually do contribute to mental health. Maybe if I wanted to expand on this toolkit, I'll probably discuss something about culture, what culture does, and to either encourage or mostly to make the mental health worse, because we meet that a lot in all the work that we do as we sit and listen to people. And many people will tell you we belong to some faith community, but the messages we get from the faith actors are not helping. And many times people feel judged and condemned rather than encouraged, and make them feel welcome to the community. And so a lot needs to happen to also address certain cultural issues that cause a lot of mental health in our communities.
Yeah,
Absolutely.
I would like to add that in addition to looking for boy or girl, we see a lot of gender-based violence, which is indiscriminate, whether someone is pregnant or they've just given birth. And some of the silent violence is the emotional violence. So someone feels, I wanted a boy, but you've only given me girls, so I'll just keep quiet on you. So I feel that the faith actors have the right platform to address all this, because we know children are a gift from God. So if that message is brought through and the congregation understands it very well, then we'll have some of these issues, you know, the mental health, the perinatal mental health really mitigated in our congregations. Thank you.
Thank you, Clayton and Anne. So there's actually a related question, which I think is a very hard topic. So Cesar from the Democratic Republic of the Congo has said that, so we have the toolkit, and we want a next step of religious leaders that should be trained so they're useful in our communities. And he said it's a huge challenge in his community where women are often raped, often from the people that are speaking. And I don't know if he's trying to say from the people that we're supposed to trust in those positions. And so it's a hard topic. It's a reality. And Clayton, I wonder if you can respond. You've done a lot with trauma counseling, and just if you have any responses to Cesar on this topic.
In our program for trauma healing that we do, it's not like a professional training, but it's basic. It provides basic skills for anyone, either faith actors, pastors, or priests, or anyone who takes care of people to actually learn some basic skills of listening. I usually tell church leaders, please listen more and talk less. Because unless we take time to listen to people, to listen to hear where they're coming from, demon possessed, or because that's how usually people are treated when suffering with the mental health. People think that you are demon possessed. They start casting demons out of you, and that has already stigmatized you. So when we learn how to listen and listen well and help people feel God in their place of suffering, it's actually what the church leaders do, and it doesn't require for you to take a 4-degree course or 5-degree course. We can provide that, and it's basic for anyone. And what I want to encourage church leaders to do, they already have so much work to do. I release the congregants, people in your congregation, to be empowered with these skills so that they can help you take care of the small things in the congregation, help people who are struggling with the mental health to have a community, a safe community where they can run to and be listened to, rather than everyone going to the pastor or to the priest, because they're also overwhelmed. If you have a congregation of 1,000, how do you get time to listen to everyone? But when we empower people in our congregation, then they are able to take care of each other. And then the burden of the pastor actually becomes less. And that's part of what we do in our program.
Thank you, Clayton. I appreciate it. I think it's a hard topic to talk about. How do we hold our leaders accountable for their actions and their voice? So it's not an easy topic. We want to ensure that our religious leaders of all faiths, who are so trusted by their communities, are walking their talk, right? And doing it in a way that is respectful and caring and loving in a safe way for everyone. So it's a very important topic. Plain people have asked about the trauma healing information, so maybe you can put that in the chat box. That would be great. We had a question from Richard from South Africa about, has there been research done on the effectiveness of a faith community's support of a mother experiencing mental health challenges? Richard, it's such a specific research project. I would love it. A few years ago, before we started on this toolkit, we actually did a literature review on, Momentum did a very broad global landscape analysis on perinatal mental health, broadly. And then we did, as the faith engagement team, a very specific oriented key informant interviews and literature review on faith and this topic. And there's not so much. So my answer would be, from what I know, I don't know that there is a specific research project on that, but I also don't want to say absolutely. So I'd have to go back to the literature review, and I'll find the link and I'll put it in the chat box. But I don't know if anyone else has comments about that or thoughts.
I work in a university. I have seen students do minimal research, and it is more to do with health workers, but not faith actors. And when Mona gave me a chance to talk about this topic, I tried to do informal research among the faith actors about how they view mental health, those who are working in faith-based health centers, and then those who are in active ministry, but actually most of them indicated that they were not talking much about mental health. So the research is very minimal.
Thank you. Well, I know we're coming close to the end of our time. And so I just would like to give each one of our speakers, if they have 30 seconds of anything they'd like to close with or share with or emphasize. So I'm going to go in the order in which you spoke. Millicent's probably like, that's so unfair. But and then I just have a few things to close with. So Millicent, over to you. Thank you.
Thank you. Thank you so much, Mona. And thank you everyone who joined in and listened and took time to listen and discuss about this very important topic. My closing remark is that there is no wellness without mental wellness. So that will be my closing remark. Thank you.
Thank you, Millicent. Anne, over to you.
Well, I'm glad that we are bringing God into a mental health picture. We cannot have mental well-being without the Creator. So it's a strong message to the faith actors that in whatever we do, the best thing we can do to humanity is to point them back to the author of life.
Thank you, Anne. Clayne, over to you.
Do you want me to go next, Mona? Okay. My closing remarks is that God says in Psalm 34:18 that God is close to the brokenhearted, and he saves those whose spirits are crushed. So if God himself is close to those who are brokenhearted, so we need to be close to those, because he doesn't come from heaven, he uses us. So I pray that our faith community will do just that.
Thank you, Clayne. Erin, over to you.
I'm just really encouraged by all of you being here. I think it shows that there is global movement towards this topic, and I hope everyone can feel encouraged that you're not alone. Sometimes it can feel daunting to engage in a hard topic like this, but there are over 100 people right here that have enough interest in it that they're willing to be here. So I'm really encouraged. I hope other people are too. I hope you'll share this resource and continue to be champions and advocates in your own space.
Yes, thank you all. I just put a link in the chat box. Richard, I'm not sure if it will answer, but to the faith-based landscape results that were in English and in Francais. So hopefully that's helpful. I also put a link. There is a global perinatal mental health community of practice. Where you are all welcome to join us and to continue discussions on this topic. I think there were a lot of issues that were raised that we couldn't talk about today, but perhaps that's something the community of practice can keep in mind when thinking about future topics of discussion. So just want you all to know that. If you are on the African continent, there is actually going to be a meeting on perinatal mental health in Zimbabwe the first week of December. And so I'll make sure to include the link for that conference in our follow-up. You don't have to be in Africa, sorry, but it's an Africa-specific meeting. And we would love for you to fill out a very quick survey to let us know what you all thought about the webinar, to give us ideas. And I think someone asked a question about, once you actually have the chance to look at the toolkit, what to do next if you have questions. You're welcome to contact us at any time. Our contact information will be in the follow-up. So always happy to answer questions, to continue to have dialogue. We had a meeting, my organization CCIH in May here in Kenya for East Africa on mental health broadly, and this was one of the topics. And since that meeting, I'm really encouraged that a specific organization wants to sensitize their staff all over the world on this topic. So we've been working with them to do a very specific sensitization in October. So we really want to continue to encourage you all to read and reflect on what's in the toolkit. We really encourage you to share it with your coworkers, to talk to your friends and your family. I think many people don't talk about mental health. And I think the more we talk about it, the more we will lessen stigma and misinformation about mental health. So I thank you all for joining. Once again, I pray that it was useful for you all. And I once again appreciate Momentum Country and Global Leadership and USAID for their support. I look forward to all the posts I'll see on social media today and later about what you've learned in the toolkit and the webinar. And I thank you again for joining us. So I hope everyone has a very good rest of your day. Bye.
Bye. Thank you, Mona, and everyone.
Yeah, thanks everyone. I hope